Hi, this is Vinayak Kumar. I am a cardiology fellow at Mayo Clinic, and I have the distinct pleasure of interviewing Dr. Ankeet Bhatt, who is a clinician researcher at Kaiser Permanente, who's here to tell us about the Implement HF trial. Dr. Bhatt, thank you for joining us.
Oh, thanks so much for having me.
So what can you tell us about your study?
Yeah, thanks so much. We've been very interested in implementation science. As you know, heart failure therapy discovery science has really moved forward, but time and time after again, we're seeing significant gaps in the implementation of these therapies in real-world practice. And so our trial was aimed at trying to figure out whether there's a solution that could improve implementation of guideline-directed medical therapy. There's been a number of trials in implementation science in heart failure. Ours was unique for a few different reasons. One, it chose the hospitalization as a potential opportune time to augment care. This is a time in which patients are highly monitored, they're able to get frequent lab testing. We also included two populations that have been generally excluded from prior implementation trials. Those patients who have de novo heart failure during their index hospitalization, and patients with HFrEF who are admitted for primarily non-heart failure related causes. The crux of the intervention was a virtual care team that was able to operate across 3 care entities in our single integrated healthcare delivery system. What this virtual care team did was analyze each patient admitted for HFrEF at these 3 care entities and provided treating teams with up to one suggestion per day as to how to augment or improve that patient's guideline-directed medical therapy.
That's amazing. And what did you find?
Yeah, so the results were really intriguing. Our primary outcome was a composite GDMT optimization score, which summed new initiations, discontinuations, and dose changes during hospitalization. We found that the virtual care team guided strategy, as compared to usual care, improved the primary outcome of a GDMT implementation score. We also looked at some clinically important secondary outcomes. So the proportion of patients who had at least one new initiation of GDMT, the proportion of patients who had at least one new initiation or meaningful dose up-titration, and the proportion of patients who left the hospital better off in terms of GDMT than they came in with. For that latter outcome, what we call net intensification, we saw a 20% absolute increase in those allocated to receive the virtual care team intervention. This is a number needed to intervene of just about 5 clinical encounters to improve one patient's GDMT during hospitalization.
That's amazing. That means a lot of patients are getting better care or more up-titrated care than they would have otherwise been receiving. Did this increase the length of stay at all?
Yeah, that's a fantastic question. We were really in tune to this because we were interested in making sure we evaluate potential unintended consequences of this approach. We did so by looking firstly at a number of adverse events. This included bradycardia, hypotension, acute kidney injury, and hyperkalemia. While these events occurred commonly amongst patients who were hospitalized, upwards of 25% of our patients, there was no excess risk amongst those allocated to the virtual care team as compared to usual care. In addition, we looked at length of stay, and length of stay in both arms, usual care and the virtual care team guided strategy, was exactly the same with a median of 6 days.
That's amazing. What was it like in terms of workload burden now that you have a new team involved in the care?
Yeah, we had a really fantastic team, and I total hats off to the physicians and pharmacists who worked with us. They did an incredible job. They used a evidence-based algorithm that had been internally developed and validated against ACC and AHA guidelines to streamline the implementation of this approach. And we really see value in potentially expanding this to either other cardiometabolic conditions, to a larger integrated healthcare systems with multiple care entities in which we can take hub care out to the spoke hospitals in a fully virtual format. So we really think that we're going to be looking more closely into how this translates in terms of cost effectiveness and time and things like that. But we see really opportunities to scale such an approach across large integrated healthcare delivery networks.
That was fantastic. Thank you so much for your time to participate here.
Well, thanks so much for having me. I've really enjoyed this.
All right. For more videos like this, please visit our YouTube channel at youtube.com/fitsonthego.